And then just moving on to TB, this is also something new in the guidelines, is that every HIV positive pregnant woman needs a gene expert to screen for TB. Because?
The sensitivity of the screening question is not good with pregnant women.
Because?
The pregnancy tends to reduce the symptomatology of the symptoms of TB.
Okay, great one. Comment? Atypical as well. And remember some of those non-specific fatigue, night sweats, women can have those, pregnant women can have those without being having TB. And the other thing is that, remember, TB in pregnancy can be extrapulmonary. It might not be in the chest. And the question is now, if they can't produce a sputum, what are you going to do? Sorry? So Dr. Vilakazi said the LAM test yesterday is for ill patients.
Yeah, for patients with a CD4 count of 100. So wouldn't you then induce this?
That's the easiest part, is that, again, please, let's not go and do chest x-rays. Okay? You induce the sputum. You send the sputum for gene expert. And then we're talking about viral load monitoring. Is that, again, we do a lot of viral loads, and some of them go unread, unreported, unresponded to. So in this case, every viral load that you do, you need to be able to get the result and also respond to it. And the nice thing about the new guidelines is that there's a lot of gatekeeping that happens with NHLS, that if you do multiple viral loads, they get rejected. So there's a code that's been provided. So every time you're ordering a viral load in a pregnant woman, please use that code, so your specimens will not be rejected. And then in terms of speaking about the specifics of timing on viral load, there are a couple of changes. So if you're newly starting ART, you still do the first viral load at 3 months. And if they virally suppressed, what were we doing previously? Repeating at? After 6 months. So now the guidance is that you do it during labor. Okay? And we're going to talk about checking of the results. If somebody is already known positive, we're still doing the same thing, is that you do a viral load at booking and you repeat the viral load at delivery if they are virally suppressed. And in somebody who's had previous exposure to ARVs, either through PMTCT or she discontinued her ARVs, then you must do a viral load before you reinitiate treatment. But you don't wait for the viral load. You do a viral load, but you start treatment. Check the viral load in a month, and then if it's going down, you check it again in 2 months, and they should be suppressed, especially with the dolutegravir that we're using. Okay. And if they suppress, you repeat the viral load again at delivery. And the importance of the viral load at delivery is to determine the response to ART during the antenatal period. And also the important part, which is also changed in the guidelines, is that it determines what kind of prophylaxis the baby is going to receive. Okay. And also it determines how often you're going to do a repeat viral load during breastfeeding. Because remember, we're saying that your labor and delivery is the highest risk period in terms of transmission. And then the next highest risk period is breastfeeding. So those are the 2 critical areas that we need to be monitoring our viral load. Okay? And then we do a viral load now at 6 months postpartum, which is a new one because we need to be making sure that she's virally suppressed during pregnancy. And in terms of during breastfeeding, we're still doing the viral load 6 monthly. So I said earlier, now that our antenatal PMTCT program is well established and well working well, majority of cases of mother-to-child transmission are women who seroconvert during pregnancy, but it's also women who seroconvert during breastfeeding as well. So our breastfeeding transmission, the estimates are that it accounts to almost 50% of cases of MTCT that we're seeing now. Okay. And the 6-monthly viral loads during breastfeeding are to be aligned with the well baby visits, which are at 6 months, 12 months, and 18 months as well. So we're going to talk about the woman who's not virally suppressed. As I said earlier, if you do have viral load, please check it and please respond to it. Any viral load more than 50, you heard Ella, it's an emergency. And it's even more of an emergency in pregnancy because you've got a limited time period where you need to get that woman virally suppressed. And you've done the A, B, C, D, and E, and it's the same thing with pregnancy, especially in terms of adherence, especially in terms of co-administration of different drugs, and also chances of having drug resistance. So there's also a concern that in our program, because we've had so many women who've been exposed to the PMTCT program, where we're starting and stopping, our baseline resistance from previous ARV exposure might be high. So now this algorithm during pregnancy and postpartum is different to the adult and pediatric cases because, as I said earlier, you've got a limited time period in pregnancy. So let's start on the left-hand side of the screen. So the pregnant or postpartum woman has a viral load of between 50 and 1,000, that low-grade viremia. So instead of repeating the viral load in 6 months, you repeat it in 8 to 10 weeks. Okay? Because again, remember you've got a narrower window, and the woman with low-grade viremia can still transmit HIV to her baby. So you need to be able to show that viral load, is it either going down or is it going up? And you want to be able to respond to it earlier than in a non-pregnant person. So if you do that viral load, you can either come back having suppressed, stayed the same, or gone up. So if we look at the group that has gone up, again, you're not going to switch on one viral load. Again, it depends on what regimen they're on. Again, you go through your A, B, C, D, and E, because I've been working with pregnant women now for over 20 years. The biggest thing is adherence. Okay, it's either they don't understand, or they don't tolerate the drugs, or there's issue of disclosure. So switching immediately is not the correct response. You need to make sure that your A, B, C, D, and E, you've gone through it, you've corrected what's correctable, and then you repeat the viral load in 4 to 6 weeks. Okay. And then if the viral load comes back, it's still more than 1,000. Now you need to think, do you need to switch to second line? And the question is, what regimen they're on. So what were we saying for the non-pregnant woman? If they're on TEE, they've got 2 viral loads more than 1,000, you switch. Same with pregnant women. What were we saying with TLD? When do you switch with TLD? 3 viral loads over a period of? 2 years. How long are pregnant women pregnant for? Not 2 years like an elephant. But again, the answer is not to switch immediately because the barrier to resistance with dolutegravir is very high. You need to be sure, and we talked about all those nuances about drug interaction. You need to be sure that she's taking her dolutegravir correctly. You know, she's spacing her other drugs correctly. Okay. And again, you individualize because the other thing, if there's immunological deterioration, patient is suddenly developing opportunistic infections. Even if you haven't reached the 2-year period, surely something is going on. And the same progression in terms of what do you change is the same as with your adult patient, your non-pregnant adult patient, is that it depends what the patient was on. So if they were on a efavirenz-based regimen, you go to dolutegravir, but you need to go through the counsel about risk of neural tube defects, contraception, fertility intentions, and all those things. And the same with your protease inhibitors, that your barrier to resistance is much higher with your protease inhibitors. The patients who are failing treatment is likely to be non-adherence than drug resistance. Okay. And then we're just going back to the diagram. So we've talked about the antenatal period. We've talked about all what you need to be able to achieve viral suppression by the time of pregnancy. Let's go to the postpartum period. This hasn't changed either. The first part is that if the woman is already pregnant, she's already on ARV, she's stable on treatment, she continues as usual at the same time that she was taking her treatment. What's changed is what we give to the woman who's newly diagnosed HIV positive during labor. Okay? What are we not giving anymore? AZT. Okay? Remember, AZT was also complicated because we had to give it how many times? 3 hourly, and then you had to remember to give a tail afterwards. And then most people were doing it very badly. So now the guidance is that we still give single-dose nevirapine because nevirapine works, and nevirapine still works. So we still give the 200 milligram start dose of nevirapine, but then we give TLD. Instead of giving AZT, we give a stat dose of TLD. So we're starting the TLD. And then postpartum, obviously, you can't counsel a woman in labor and tell her about all the risks of dolutegravir and all sorts of things. You give her the TLD, and then the following day, when she's delivered, she needs to get the full counseling about TLD. And again, the postpartum period, we know that it's a tricky period for all sorts of reasons. There's a new baby, she's not sleeping well, there's postpartum depression, which you often don't screen for, or she's going back to work. So it's a period that woman is likely to be non-adherent to treatment, and we also need to know where she's going to receive her follow-up care. Because what often happens is that the woman will be referred to the hospital, and then she will be given her ARVs in the hospital. And then she doesn't go to her antenatal clinic, and she's registered as lost to follow-up. And then what do we do after delivery? We send her back to a clinic after delivery. Okay. And again, it's something that we need to be able to negotiate because we know that TIA is not networked, so you can't link patient in one facility to another facility. So there needs to be communication. We also need to be able to communicate where she's going to follow up on her 6-day visit. And why is that critical in these guidelines, that day 6 visit? Viral load. Because remember that day 6 visit is where the intrapartum viral load is going to be checked. The result is going to be checked. And then it's going to determine whether you continue with one type of infant prophylaxis versus another type of infant prophylaxis. Okay. And you give a referral letter when necessary. And you also give her a 2-month supply of ARVs when she leaves the facility. There is a lot of information, but we can get it right. We can get it right, but I agree that there's lots of bits and pieces. And remember, if the woman fails treatment, the repercussions are dire. Okay? And we've already done so well in terms of decreasing of our mother-to-child transmission rates. So we need to do well on this as well. Okay. And the other thing, we've talked about all these challenges in the postpartum period. There are a lot of support things. There's Mom Connect that the mother can be connected to. There's mentor mothers, there's support groups. And the other thing that's been added in the new guidelines is postnatal clubs. Okay? So postnatal clubs are going to be introduced, and they've been shown. In Cape Town, there's no Western Cape in the room. MSF has done a lot of work in terms of postnatal clubs, and they've shown that they improve retention and viral suppression. Okay. And again, that treating the mother and the baby together in the postpartum period and timing the visits for the baby and the mother is to promote adherence and retention in care, making sure that she's virally suppressed, and also to promote breastfeeding. Okay. With infant feeding, again, with the multiple changes in guidelines, there have been several recommendations, but now the recommendation is that we are promoting breastfeeding, but we are promoting safe breastfeeding. And safe breastfeeding means that the mother must be virally suppressed. If she's not virally suppressed, baby must be on high-risk prophylaxis. And we'll talk about what the prophylaxis is here. Okay. So again, just to summarize, is that at all those different time points during pregnancy, labor, and delivery, postpartum period, the most important thing is achieving viral suppression as early as possible, rapidly as possible, as long as possible. And not to forget that we're always talking about the baby, is that the mother is important, the mother's health is also important. PMTCT is about keeping the mother healthy, keeping the mother alive. And viral suppression equals to a healthy and the mother who's alive.